Good afternoon all. I am going to talk on corneal topography parameters among children with systemic atopy or allergic conjunctivitis, which was a cross-sectional and observational study. Allergy is an exaggerated IgE-mediated response in atopic individual. Allergic conjunctivitis occurs in 10 to 30% of the general population. Predisposing factors are genetics, inflammation, atopy, pollution, and these patients mostly have itching and eye rubbing. Ocular morbidities associated with allergic conjunctivitis are corneal ulcers, scars, ectasia, dry eyes, and refractive errors. So there is no defined place of allergic conjunctivitis in atopic march, which states that atopic march proceeds with eczema, food allergy, rhinitis, asthma. Corneal topography changes are well documented in allergic conjunctivitis, but what about the status of cornea in other systemic allergic disorders? The aim of my study was to compare corneal topography parameters in children with systemic allergies without any eye symptoms and those having ocular allergies. Materials and methods it was conducted in Department of Ophthalmology at a tertiary care center in North India. Recruitment was done after IRB clearance. Study period was of 6 months. Calculated sample size was of 74 patients per group, providing 80% power, but due to limitation of the time, we took 60 eyes in each group. 3 groups were there. Group 1, patients with systemic allergy alone. Group 2, patients with ocular allergy. And Group 3, patients without any systemic allergy or ocular allergy. Disease duration was at least 1 year in groups 1 and 2, and in group 3 we took normal population. And these were the exclusion criteria. Complete eye evaluation was done from history till oculus pentacam. The following corneal topographic parameters were studied, and the comparison of corneal topography parameters was analyzed between the 3 groups. The percentage of patients with abnormal corneal topography value was noted in each group, and the sensitivity and specificity of parameters were analyzed using the ROC curve. This was the statistical analysis used, and age group was comparable. These 3 groups were compared using one-way ANOVA. Further, we used post-hoc test, and what we found was that abnormal Kmax value was there in 21.7% of the patient in allergic conjunctivitis group, in 6.7% of the patient in systemic allergic group, and 0% in the control group. Abnormal D value was found in 26.7% in allergic conjunctivitis group, 18.3% in systemic allergic group, and 1.6% in control group. And abnormal IgG values was found in 63.3% in allergic conjunctivitis, 51.7% in systemic allergic group, and 20% in the control group. The ROC curve was drawn, and according to it, the area under curve, the BAJPAI was having the highest area under the curve, which was 0.639, followed by IHD and then Kmax. With the ROC curve, we identified that BAJPAI and Kmax were found to be the most sensitive and specific parameters respectively. So the previous literature reviews have shown the positive association between allergic conjunctivitis and abnormal corneal topography parameters, but the corneal changes in systemic allergies have never been studied. So the strength of this study was that it was a novel study to demonstrate corneal changes in patients with systemic allergies without any eye symptoms, and abnormal topographic parameters can be a potential marker of conjunctivitis with the predictive, preventive, and therapeutic capabilities. The limitation of our study was that a follow-up of patients in systemic allergic group for development of eye manifestation was not done, and the sample size was small. So I conclude that systemic manifestations of allergy should be considered as a risk factor for abnormal corneal topography, thus warrants routine eye screening to detect subclinical disease. BAJPAI and Kmax were found to be the best parameters to predict ocular involvement early in atopic patients. It is worth exploring their predictive and preventive ability for atopic march progression. So, scope for further research is that multicentric studies with large sample sizes are required, recruiting patients at different stages of atopic march to study corneal topographical changes and the onset of clinical disease with long-term follow-up, and the predictive ability of topographical markers as potential biomarkers need to be explored. These were my references. Thank you.
Thank you, Smriti. 2 questions. One is, were your 3 groups age and sex matched, or at least age matched?
So age was matched in group 1 and group 2, and in group 3 the age was a little bit on higher side, like it was 11.6 years average. So p-value was different.
Okay. And what kind of systemic allergic diseases were you looking at? Asthma, skin eczema, or
Yes, sir.
any third?
So asthma, skin, eczema was there, asthma was there,
So if there was
bronchitis,
only,
rhinitis.
Any one of these or a combination was
So
taken?
any one of them, like the skin diseases which come in atopic march, we were taking those patients and who were having those manifestations for 1 year.
And there was no distinguishing between those having, say, bronchitis and those having eczema?
So
in the-
I differentiated them also, but I haven't included that slide
this.
here.
Okay.
But it was very small sample size,
Yeah,
so
because
I
small
couldn't
sample
conclude it.
Okay.